Hello everyone, my name is Daphne Mavenu and I'm Deputy Programme Director at UCLPartners for our Proactive Care and CVD Prevention team.
Hello, and my name is Matt Kearney. I'm a GP and I'm a Director at UCLPartners. UCLPartners is one of the academic health science networks in England, and it is essentially a partnership between the National Health Service, academia and industry in order to drive the adoption and spread of innovation. I was the previous National Clinical Director for CVD prevention in England and was co-founder of CVD Prevent. The pandemic has disrupted care, as we all know, and that's led to major challenges for clinicians and for patients. But as we all know, it has also given rise to significant opportunities. And it's about some of those opportunities we want to talk to you about today. We're going to describe the UCLPartners Proactive Care Frameworks that we've developed to help GPs and their teams restore proactive care and transform proactive care for people with non-communicable diseases. The frameworks are rapidly gaining traction across England and have now been adopted into a national programme called NHS Proactive Care at Home. So the recovery from the pandemic in primary care offers a real opportunity to bring a population health management approach to transforming the management of non-communicable diseases. So just to mention at the beginning, some of you may be aware, but the primary care in England went through significant changes over the last year or so, and all general practices, GPs and their teams are grouped together in primary care networks that serve varying numbers of population, but on average 30 to 50,000 people. And working together in these primary care networks, it is now expected that GPs and primary care teams will take on much more accountability for population health, but working together across their populations, but with better integration between health and social care to deliver more proactive, personalised and coordinated care for patients. And as part of the change in 2019, significant numbers of new staff have been brought into primary care networks, clinical pharmacists, but also roles such as social prescribing link workers, health and wellbeing officers, etc., in order to support that wider health improvement for populations. So there have been significant changes in the structures in primary care, but pretty similar challenges remain. And reflecting those challenges, when NHS England published the long-term plan in 2019, there was a big focus on CVD prevention, with an ambition to prevent 150,000 heart attacks, strokes and cases of dementia over 10 years by optimising the diagnosis and management of high-risk conditions for CVD, so high blood pressure, high cholesterol and atrial fibrillation. And what we know about those conditions is that, well, they're largely managed in primary care. They are major causes of cardiovascular disease, but they all suffer from late diagnosis, under-treatment, and significant variation in care. So when I was a medical student, I was taught the rule of halves for blood pressure, for example, which meant that I would, as a doctor, detect on average 50% of people with hypertension, and when I detected them, I would manage 50% optimally. Well, 30 plus years later, we were up from 50% optimal management rates to about 67% management rates. And we see that rule of halves applying across the high-risk conditions and other non-communicable diseases. So we know, of course, that COVID-19 has had a huge impact on healthcare, secondary care, but also primary care. And in England, there was an overnight transformation in the way that we work, with new models of care, much of our care being done remotely, reduced access to face-to-face consultations. Because of the risks of infection transmission, patients didn't want to come and see us, and we didn't want to see patients in that public space. And with the big focus on the acute response to the pandemic, there's been a major disruption in routine proactive care for people with long-term conditions like cardiovascular disease, high blood pressure, diabetes, and COPD, for example. And with that disruption, it's very likely, and we're all quite concerned about it in primary care, that we will have further waves of demand. As we recover from COVID, we will have further waves of demand in primary care and secondary care from patients who have suffered deterioration or exacerbation or complication because of suboptimal care. So there is really an urgent need to do things differently in primary care at the moment, but also a significant opportunity. If we're doing things differently, we could also do things better. So it's in response to that, in response to the urgency, the need to do things differently. In UCL Partners, we have a strong primary care team of GPs and pharmacists and non-clinical staff. And together we've developed a series of frameworks for primary care to support proactive management of non-communicable diseases in primary care as we emerge from COVID. And this is an important slide as it highlights the 4 core principles of this approach. So first of all, that we should expect consultations and interactions with patients to be virtual, certainly where appropriate, but much more of the time, but of course face-to-face where needed. Secondly, that we should mobilise the wider primary care workforce, including pharmacists, but also staff such as healthcare assistants, nursing advisors, pharmacy technicians, other clinical and non-clinical staff to support delivery of proactive care in this new way. Thirdly, that if we are now confronted with the necessity of doing things differently, let's use this as an opportunity to get a step change in support for self-management. We know in primary care how important that is for our patients, but we know we're not very good at it. And we often lack the skills to do it well, but we certainly lack the time in busy primary care consultations where patients have multimorbidity generally. And the fourth principle was that we should underpin this by digital and other innovations that support self-management and remote management. In UCL Partners, the frameworks that we've developed cover 4 cardiovascular conditions and 2 respiratory conditions, as you can see on the slide. And this is the broad approach that we've taken. This is the underlying framework, if you like. So at the centre, you see for whatever condition we're looking at, that we should build search tools for our patients that stratify according to severity or priority. And this allows us to do something that's really urgently needed at the moment, is to prioritise the care that we're providing for patients. So if we've fallen behind, if we know that lots of patients are suboptimally managed as a result of the pandemic, who do we need to see now? Who do we need to see early? And who can we safely phase to later on? So that's a really important principle at the centre there. But then if we look at the other box, and this is a major part of the innovation in the proactive care approach. So using the healthcare assistants or the nursing advisors or pharmacy technicians, these wider staff within primary care perhaps who are used to seeing and talking to patients, non-clinicians, but with the appropriate training, can provide important support in 3 areas. One is that they can collate information that the clinician will need in order to optimise therapy. So gathering up-to-date information about bloods, getting the patient's blood pressure or weight and smoking status if they're able to provide that from home, running established risk scores that have been automated in primary care systems like QRisk, for example. The second area they can focus on is through supporting self-management for patients, supporting them with education about their condition, helping them to understand what is cardiovascular disease, what is blood pressure, what is diabetes, how does it affect me, what can I do about it, when do I need to seek help, and using a lot of the available published resources on websites, for example, the British Heart Foundation or Diabetes UK. But within that, they can also support patients to look after themselves. So teaching them how to do their blood pressure, how to check their feet if they have diabetes, understanding what are red flags, when do I need to seek help. And the third area that they can provide support is around lifestyle behaviour change. So providing brief interventions and digital signposting for support with smoking cessation, weight and physical activity, etc. And the lower box there is Really, this is just aid memoir rather than comprehensive, but it lists what a clinician would do for patients with each of these conditions, and that's around optimizing therapy and minimizing risk and complications. So for each of the frameworks, there are 5 elements. So we've built search tools that can apply to any of the main GP practice IT systems in England. These search tools stratify the patients according to clinical and other criteria. We've developed pathways that are not blueprints, but they're pathways for local adaptation that help us as clinicians to prioritise patients, support remote delivery of care where that's appropriate and helpful, and also to focus in on what is it that other members of the wider primary care team can deliver to support patients in proactive care. We've developed a range of scripts and protocols that guide healthcare assistants and other staff in these consultations so that we know there's a standard to what they're delivering. And we've developed training packages and collated digital and other resources that support remote care and self-care. So I'm going to just go through a couple of examples of the frameworks. And firstly, looking at hypertension. And for each of the conditions, there are a range of resources that you can access on our websites. For each condition, there are multiple slide sets, for example, that can support clinical care. But this is just a headline. This shows, first of all, the approach to stratification. So you can see prioritization at the top there, depending on the most recent blood pressure reading. So patients with a blood pressure above 180 over 120, and all GP practice will have some patients with blood pressure that's high. They are the first priority. Priority 2 with a lower level of blood pressure, but we've included in that group patients from Black and minority ethnic communities with blood pressure at a lower threshold. In the green boxes on the right, that's priority 4. These are patients with normal blood pressure, controlled to target, as recommended by NICE in England. In the grey box underneath these, again, this is aid memoir of what a clinician would do, and that's about reviewing results, optimizing cardiovascular risk, optimizing clinical management of the blood pressure, checking for complications, need for further investigations, etc. Again, much of the workforce innovation here is in the green boxes. So if you look on the right there, for the patients whose blood pressure is normal or meeting target, these individuals do not need a clinical intervention, at least for their blood pressure, but they do need support with education, self-management, and lifestyle change. And this is support that is detailed there that can be provided by the healthcare assistant, pharmacy technician, social prescriber, etc. And it focuses on teaching blood pressure technique, giving information about cardiovascular risk and blood pressure, etc. And also identifying red flags where the patient does need to see a clinician. But of course, this support doesn't have to just be provided for patients at low risk with normal blood pressure. The green box across the bottom there shows that this support can actually be provided to all patients at high risk who need more urgent clinical review, but it's care that can be provided separately from the clinician's involvement, so reducing work for the clinician, helping them, giving them more time to optimize clinical therapy. And this pathway I'm showing to illustrate the heart of our approach has been to focus less on the what to do, because broadly we know that in primary care. Where we're challenged is on the how to do. How do we deliver this in the real world in primary care? How do we get most of our patients managing their blood pressure at home in the new real world post-COVID? Well, the central line there is patient has a blood pressure monitor of their own and they submit a reading. On the right there, we focus on, so if patients don't have a blood pressure monitor, some of them will not want a blood pressure monitor or will not be able to use them, and they need a local pathway to support management, seeing someone face to face. For people who don't have a blood pressure monitor, they will need help in choosing one that is affordable and valid, and the healthcare assistant or social prescriber can support them to do that by text, by phone, by video consultation. In the centre there, you see support by these wider staff members for the patient who's got a blood pressure machine. We know that a significant risk in this pathway is that many patients will not use a machine correctly. So the healthcare assistant or other worker can use a video consultation to show the patient and to how to use a blood pressure monitor and to check their technique. And that lends itself very well to group video consultations with patients. But another real-world challenge in managing blood pressure at home is that if a patient has atrial fibrillation that's diagnosed or undiagnosed, then using an automated blood pressure machine at home will give erroneous results. So the healthcare assistant or the nursing advisor can again use a video consultation showing the patient how to check their pulse rhythm, using great resources that are available online, for example, on the British Heart Foundation website. If the patient's pulse is irregular, or they think it might be, or they're not certain, then we've put in place a pathway for diagnosis of atrial fibrillation at home using innovations such as FibriCheck, for example, where it can be done remotely using a mobile phone. So this pathway, again, is just to illustrate our focus on the how to do things differently. And we've taken this approach with our other resources in other conditions. And I will go more briefly through the other conditions just to illustrate the broader approach that we've taken. So we know that cholesterol is one of the high-risk conditions. But one of the challenges around cholesterol, real-world challenges, is that there are huge numbers of patients who should be on lipid management therapy for secondary prevention or primary prevention. It's a challenge in primary care. Should I prioritize this now? How many patients are there? We know that there are millions across England, for example, in this category. How should I prioritize? Who should I see first? So the stratification in the centre allows us to do that. And we propose starting with secondary prevention because the population health gain will be greater and quicker. And we've shown an approach to stratifying. The search tools that we've built identify people with existing cardiovascular disease who are not on a statin, and then those who are on a suboptimal intensity or dose of statin. The box at the top shows what the healthcare assistant can do. And again, it's the same principle. Gather information so it's in one place to support the clinician, support the patient with self-management, education around their condition, and support for lifestyle change through brief interventions and signposting. Again, reducing time the clinician has to spend, but improving the personalised care offer, the support for self-management for the patients. And the lower box, again, it's aide memoire. It just lists what we would do as clinicians to optimise therapy. And then this slide illustrates a very similar approach for primary prevention. It's just the stratification in the centre that is different, but it allows GP units, GP teams to phase their work over 6 months or 12 months in this group of patients and to know that they're doing that phasing in a safe way. And for type 2 diabetes, the slide looks slightly different, but the approach is the same, with using stratification, building search tools that help to stratify patients according to their HbA1c or blood sugar control levels, but also includes complications, comorbidity, social factors, and ethnicity. And I won't go through the detail of this slide, but the slides will be available. But you can see the broad approach, taking a evidence-based approach using NICE guidance, but also a pragmatic consensus approach to stratification over time. And then the next slide shows how this stratification can be used to stratify the workload and use the workforce, for example, using the healthcare assistants or social prescribers, again, to support education, support for self-management, support for lifestyle change, checking on medication adherence, identifying red flags, when to refer patients to a clinician, so that patients with very good diabetes control and at low risk will maybe low priority for a clinician, but could still get that more urgent support for education, self-management and lifestyle change. And those interventions can also be provided to patients at high risk to reduce the workload for the frontline clinician. And we've developed similar pathways for atrial fibrillation, for asthma and for COPD, and all of those are on the website. So I'm going to hand over to Daphne now.
Thank you, Matt. So as part of the development of the frameworks, it was important for UCL partners to test the materials with the patient and public representatives to really make sure that the frameworks will land well and best support the needs of this patient group. So we held a virtual engagement session in 2020 and identified several key themes. The first was around communication. Patients raised concerns about not having regular communication with their GP, but they did say they would be happy to hear from someone who they felt was confident and was providing consistent messaging that they would usually hear from their GP. They also were keen to have someone who had access to their existing health information to reduce the need to repeat this kind of information that their GP would already be aware of. Patients spoke about wanting a holistic approach to support. So support should go beyond the individual condition that they're being called about and take into account the wider person's mental and physical well-being. And trust was a key theme also raised. Patients raised concerns of fraud or breach of confidentiality when being contacted, and they also spoke about wanting a single number or named person to call if they needed support urgently. These themes have been incorporated into our frameworks. As it's been mentioned, we developed the frameworks also in close consultation with a wide group of clinicians who work closely with UCL partners and are part of our core team. Implementation support is critical to go alongside the various elements of the frameworks, and this is to ensure that they are implemented consistently and there is no exacerbation of health inequalities due to the cohort of the willing going forward rather than everyone participating in implementing these frameworks. So there's different types of support available. First, alongside our search tools. So there is a webinar on our website and ongoing virtual support that can be accessed to ensure that these tools are used appropriately to support the identification of patients. We've got various resources that support workforce training and support, which I'll provide more information on in future slides. And we also have information around digital support tools. So digital tools are really an important element of this program to enable remote management and self-management for each of the conditions. We signpost to these resources on our website and also a practical implementation support about how to use them with patients. So we have several resources for clinical management, and these slide decks are a way to support clinicians to clinically manage the comorbidities that patients may experience. So for example, the hypertension pack also includes cholesterol management, and the diabetes and AF packs include cholesterol and blood pressure, recognizing the comorbidities that exist for these patient groups. We also have a protocol and several others that provide support for remote consultations for healthcare assistants and similar workforce groups. And these are multi-morbidity packs as well that allow the healthcare assistant to have a conversation that recognises the different conditions the patient may have. We also have various signposting to different resources. So there's great resources available from major charities like British Heart Foundation, Diabetes UK. So we provide a list of these within our protocols and packs for healthcare assistants and other members of the workforce for them to share with their patients to help them manage their conditions well from home. We also signpost to an NHS website called 1U that provides great resources for behaviour change. So advice on how to quit smoking, to eat more healthily, and to increase physical activity, which all can impact on better managing long-term conditions. As mentioned, we signpost the different digital tools that can be used to support the management of long-term conditions. And we have a commercial and innovation team within UCL Partners who are very closely involved in this aspect of the programme and have relationships with industry partners to support our local teams to be able to integrate these tools into their own pathways and condition management for patients. So here's a still of our website and a link where you can go to access the various resources that have been shared. So last year we did a lot of engagement work and there was great traction and engagement around our frameworks. And this led to the frameworks being picked up by NHS England Improvement to form the basis of a national programme called Proactive Care at Home. We've begun the programme with 4 pilot sites across England who are really testing the implementation of these frameworks within their local geography. 2 of these sites are integrated care systems within the UCLP geography, North East London and North Central London. And the experience of supporting these sites is really helping to continue to develop the tools and resources that we have available. Outside of the pilot programme, there are further 6 academic health science networks across England who are supporting the local rollout of the frameworks. And we've had over 2,700 downloads of the search tools to date, showing the wide use of these. And we know that there are some systems who will download the tools once and then share it beyond. So this is probably an underestimation of how widely the tools are being used across England and beyond. So as mentioned, North Central London falls within the UCLP geography, and we have worked with one of the primary care networks, Enfield Unity PCN, who are serving a very large population of over 150,000 patients across 23 practices to implement the proactive care frameworks. Within this PCN, there are over 25,000 people registered with diabetes. Given this number, they chose to initially focus on implementing the diabetes framework. There were 3 key aspects of this implementation. So we focused on training to really ensure that the workforce had the appropriate skills to implement the frameworks. And the approach we took was to integrate the training into existing career and competency frameworks for diabetes nurses. Lead diabetes nurse was appointed to train the wider workforce. And UCLP provided communication skills training and the protocols that have been referenced in this presentation. The workforce are obviously a key element of implementing the frameworks. So we utilised the new roles within primary care networks, including health and wellbeing advisors, and had a lead GP with a special interest in diabetes, focusing on supporting the higher risk groups within this cohort. Continual measurement was also a key aspect. So we supported Enfield Unity PCN to develop a dashboard on their local data management platform to measure the real-time progress to help inform how they should continue to approach implementation of the frameworks. From this experience, some of the successes we've seen are development of strategies for remote monitoring, which is key to implementing these frameworks, particularly in the midst of a pandemic. We've had really positive feedback on the training and competency framework to support the upskilling of the wider workforce. A key challenge, as to be expected, is the disruption caused by the pandemic. It's really difficult to define what good looks like in the midst of this and see hard outcomes. There have been really useful enablers to support the implementation of the frameworks. So program management has been key. UCLP offered this skill to Enfield Unity PCN, supporting the ongoing delivery, development of project plans, and facilitation of regular meetings to ensure that there was progress for this work. We supported them to develop clear clinical and operational roles to ensure that there is local ownership and it's not just an outside organisation supporting the implementation of these frameworks to enable longer term sustainability. We developed strategies for engagement and training, which was key, and supported the appointment of long-term condition champions across the sites, who were both clinical and operational. I'll hand over to Matt to finish off the presentation.
Thank you very much, Daphne. So we're all responding to the challenge of COVID, and we know the very worrying impact that's had on wider healthcare provision and potentially outcomes for our patients. The frameworks are to support primary care to adapt to that challenge. But it does bring us a significant opportunity, not just to restore services, but to improve the health of our populations. And core elements of this population health management approach are risk stratifying patients so that we prioritise care and focus in on those with the greatest need, mobilising the whole of the primary care workforce, and I think one can be very innovative about this. As I mentioned earlier, staff within a primary care team or unit who are used to conversation with patients and who are motivated with the appropriate training can provide some of these wider this wider support for patients, and that is support that will help to optimise self-care and really personalise the care offer for patients. But in addition, in doing things differently, doing things in a structured way, focusing particularly on patients who need treatment optimization, it really gives us an opportunity to optimize clinical outcomes and reduce variation across the patch. So I think it gives us a platform for doing things differently and delivering significant gains in population health. So we hope you've enjoyed the presentation and found it useful. Do visit the website where you can find all of the tools and resources that are free. Thank you very much indeed.